Good evening, everyone. I am Manu de Volder. I am the national delegate for the EBCP in Belgium. And with BelSECT, we want to welcome you on this first EuroFusion webinar of 2022. And I want to take the opportunity to wish you all the very best for this year. Hopefully a year we can go a little bit back to the life we had 2 years ago with less online and more real-life events. But on the other hand, I have to say that this EuroFusion concept is a great way to use the online technology we know nowadays. We have already had some interesting evenings with the previous editions. And of course, we hope to add another interesting one today. We gave this webinar for this evening the title Improving Daily Perfusion Practice. So our program is based on cases and experiences from our daily practice. And we also focused a little bit on how can we improve our day-to-day work. But first of all, we will give you an insight, a presentation of perfusion in Belgium nowadays. We have Corneel van de Wiele as first speaker. Corneel is perfusionist at the University Hospital in Ghent, and next to his clinical work, he is also very committed for perfusion in general as Congress organizer for the EBCP and president of our Belgian Perfusion Society, BelSECT. So Corneel is the ideal man to present us the current situation of perfusion in Belgium.
Thank you, Manu, for this nice introduction. And also, I should thank you a lot for organizing this event as the EBCP delegate of Belgium. Also, I would like to thank my colleagues Dimitri, Herdi, and Kenny to be able tonight to give a scientific presentation. But for myself, I'm really proud and it's an honor for me to give you an introduction to our country, but especially to BelSECT, the Belgian Perfusion Society. So to get started with, I think everybody knows Belgium as the country which is famous for its beer and its chocolate, but also for this small peeing guy. But nevertheless, there are some misunderstandings, or there have been some misunderstandings in the past. So to be correct, it's really important for you to understand our political system tonight, because that will make it clear the problems we are facing as perfusionists. So to start with, Belgium is the country and Brussels is the capital. Very important for you to know that. But what is more important is to realize that we have actually four important communities in our country, which is the Flemish community, the French, the German-speaking community, and Brussels. Those are all separate. So this is our country, which has 11.5 million inhabitants, and also we do not really have a real Belgian language. We have actually 3 official languages. So in Belgium, we have 29 heart centers, and we are performing around 10,000 surgical cases each year. So that means that we have not really very large cardiac centers, and we have several small volume centers, which has its advantages, but also has its disadvantages for sure. But we are not only performing, of course, cardiac surgery, especially the last 2 years have been really tough for many of my colleagues throughout the world, but also in Belgium, because of the COVID pandemic. And here you can see in this plot the 4 waves. We have 4 waves we have been faced to the last 2 years. The blue line is actually the ECMO activity in our country. So now we have still 33 ECMOs, COVID ECMOs running. But luckily these figures are going down the last few weeks. But the red line shows actually that the number of hospitalized patients is increasing again, probably because of the Omicron variant. But especially last year in November, we had this peak when we had around 100 ECMOs, which was very close to the limits and the capacity in our country actually. So something more about BelSECT. We are a non-profit organization unifying the Belgian perfusionists, already founded in 1979, which was really soon, I think, in Europe, really at the beginning of perfusion in Europe, I think. You can visit our website, www.belsect.be. The mission of our society is to develop the profession in Belgium. and represent Belgian perfusionists in the European board, but especially in the committees of the authorities in Belgium. And I will discuss a little bit further on that within a few minutes. This is really important for our society. But the most important aspect of BelSECT is, I think, to educate each other, to meet and discuss our findings and our experiences with one another. And nowadays, we are trying to do that with webinars, but we also have our 2-yearly conference, which is organized by our society. So we have around 100 members last year. This is an organigram. So we have a BelSECT board, which is represented by 3 Flemish and 2 French-speaking perfusionists. So this is really important for our organization to keep that balance a little bit. And we only have 20 members in our who are active in the committees. So I'm really thankful for those people that are assisting our society. But I think this, as a chairman of the organization, I think this can and this should increase in the future, because it's a lot of work, and there are also some new stuff coming towards us, I think. And for that, we really need more people to help us. I think we can also be very proud that more than half of our perfusionists are European board certified. So a little bit, some information about our committees. The first one is the communication committee, who is actually delivering a monthly newsletter to our members and also representing BelSECT on social media. The scientific events committee, which is a really active committee. They are responsible for organizing 3 to 5 educational evenings in Brussels each year. They are also organizing this year, 2022, the BelSECT meeting, which is a cooperation between BelSECT and the Dutch Perfusion Society, which we have been doing for several years now, and which is really interesting to hear people from other countries and to hear other insights, and especially the way they are organizing their society is very interesting for us. We also this committee also organizes every 2 years a speed date with our sponsors, which is really interesting for everyone. And it's not just a commercial speed date, it's more like a scientific approach of the products our sponsors are actually delivering to us. And it's really well appreciated by both our members and also our sponsors. And as I said before, we have our international symposium 2 yearly on perfusion technology. The educational committee, they're actually the safeguard for the quality and the conformity of the educational system of perfusion and the training of our perfusionists. In practice, this means that they are the connection between BelSECT and the perfusion schools. They are also organizing the EBCP examination. And because there is such a close connection between the schools, with the schools, we always demand that the coordinator of this committee is actually someone who is responsible for the perfusion school. And this can change. It can be someone from the French part of the country or the Flemish part of the country. Something new we have started last year within this committee is the recommendations. So this committee is actually doing some literature research and is actually making some recommendations for our perfusionists. They are not published on our website yet, but that should come within a few weeks, I think. Manu is responsible for that. So up until now, they have written 2 protocols, one for the urgent oxygenator changeout and one for the massive air embolism during cardiopulmonary bypass. So there are more protocols to come in the future, because we think that BelSECT should actually give some protocols and some procedures to their members, which they can adapt at their own hospital, actually. Yeah. And now the most difficult part of my presentation is the governmental committee. As I said, we have a little bit of a strange and a difficult organization of the governments in our country. So this is the committee which is responsible to stay in touch with these authorities and represent BelSECT in their meetings. And what we are doing, actually the main purpose of this committee now, last few years, is actually to follow up the process and the decision making concerning our profession. because that's a really big problem in Belgium. Perfusion in Belgium is not recognized and is even not defined. So it is not really clear who should a perfusionist be, what can they do, what are their competencies, what can't they do, and what education should they have before being able to perform perfusion. So that's a really big problem for us, especially for the liability. For example, if someone makes a mistake and this has serious consequences for the patients, who will be responsible for that? And it's not very clear if the acts we are doing each day, if we are really allowed to do them. So that is a really big problem for our members. Nevertheless, the word, this is a bit of Belgian law text, which is in Dutch, unfortunately, but in the Belgian law book, there is only one time the name of perfusionist is mentioned in the text, but nowhere else there is actually stated who is this person, what should they be studying, or what are they able to do, what aren't they able to do. So that is really strange and a big problem. Nevertheless, we have 2 perfusion schools, we have training programs, we have a school in the French-speaking part of the country and in the Flemish-speaking part of the country. Those 2 schools are a little bit different. They are both European board accredited, of course, but the main difference is, or the first main problem actually, is that we only get a certificate of perfusion. But in the French-speaking part of the country, you have the option to follow perfusion incorporated in a master's degree, and then you actually get a master's degree in public health with the option perfusion. In Leuven, you get a certificate, and with that certificate, you can get an exemption for studying the master in nursing. And in both schools, a thesis is required for graduation. So this is the situation in Belgium. The only thing that is required is actually that we are nurses. We have the Bachelor of Nursing, and preferably we have a specialization in intensive care. And then you can actually follow the certificate or the basic competence in clinical perfusion. This is not obliged actually, but most hospitals request the perfusionist to have this certificate. Of course, BelSECT is always, and also the hospitals are stimulating people to recertify and to ensure the continuity of the perfusion care. But also, this is not requested, it is just stimulation. And then when you have the certificate of perfusion, you have the option to follow a master in nursing with the specialty of perfusion. But this is an option, and some people are doing it, some people are not doing it. But you don't have to get this degree to be able to perform perfusion in Belgium. So that means actually that every nurse in Belgium can do or can perform cardiopulmonary bypass. So what we are doing now, we are trying to sync the 2 perfusion schools of Liège and Leuven. And this is really important, and it's very important that you pay attention now, because it will get a little bit difficult. So this is our country, and in our country we have several governments. Each community has its own government. For example, in Flanders we have the Flemish government. In the French-speaking part of Belgium we have the Walloon government, but we also have the French community government. And both of them have different different tasks actually. And then we have the German-speaking government, which is a little bit smaller, but we also have the Brussels government. And yeah, above this all, we have the Belgian federal government. So that means that we actually have 6 governments. And that makes it really difficult for BelSECT to be able to achieve a recognition of the profession. For example, if we want to sync our perfusion schools, we have to go to the educational ministry. But as you can see, we have actually 4 ministries of education. And once we get these degrees recognized by these different ministries, this would mean that we would get a recognition of the Ministry of Well-being, of which we also have 4. And only when we have the recognition of these 8 ministries actually, then we can go to the federal government, because healthcare is actually part of the federal government. And then once we have all this, then they are actually able to recognize perfusion as a profession. So as you can see, we really have a long way to go. It's really difficult to be able to achieve something. And it takes a lot of time. And the biggest problem actually is that when you achieve something, often there are new elections and the coalition changes and you have to start over all over again. Yeah. So the next steps for us for the recognition is actually to recognize our educational degrees in both parts of the country. We have a description of the profession, but we should get this description recognized by the ministries, and only then we can get a recognition as a perfusionist. So for the near future, what is BelSECT offering to our members, but also to other members of the European board, I think? We have the educational evenings. We have the scientific day with the Dutch Society in September, where we will also have the speed date with the industry. Next year in 2023, we have the international conference of BelSECT, actually, which is always held in Brussels. Last year, we will actually trying to have this multi-hub concept, but because of COVID, this got cancelled. But we think that that's a multi-hub concept will actually bring the conference more towards the people instead of demanding the people to travel towards the conference. And this can be especially important during the COVID pandemic, I think. But this could also be important for the European board conference, I think, where people are not always able to travel a lot or to come to Barcelona or Milan. And then maybe it could be an idea to bring the conference in several hubs towards the people, avoiding the traveling. Yeah. Another one of my ideas, which I was really hoping to discuss a little bit tonight, was the idea of organizing a pediatric perfusion symposium, because I think as a pediatric perfusionist, that is something that is really lacking in Europe these days. And I think if we work together as countries, we should be able to organize such a symposium. So it's my question as the chairman of BelSECT, if you are a delegate or if you are involved in another perfusion society within Europe and you want to cooperate with us to organize several stuff, please contact us. Do not hesitate. We are always willing to cooperate. That was the presentation of Belgium and the BelSECT for tonight. So thank you for your attention and see you soon.
Thank you, Corneel, for your very clear presentation of our situation. I saw already some questions in the chat, but we agreed to take all the questions at the end of the webinar. So maybe we will come back to you then. Our next speaker is Kenny van Zwan. Kenny is my colleague perfusionist at the University Hospital of Leuven. And next to that, he is also involved in BelSECT as the chair of our scientific committee, organizing our conferences and educational evenings. And today he will present a case study of a patient we had last year in our center with hemophilia who needed an aortic valve replacement. Kenny?
Yeah, do you hear me loud and clear?
Yes.
Okay, and you see my presentation?
Yep.
Okay, here we go. So thank you very much, Manu, for the kind introduction. We're gonna talk about this case. It's not that easy because it's a lot of coagulation tests and difficult stuff, but we'll get through it. So we had this 57-year-old male, 173 centimeters high, 75 kilograms. He had a history of smoking, and also he had a congenital hemophilia A with very low activity of factor VIII. He also in the past got infected with hepatitis C because of plasma transfusion, but since a few years that's perfectly curable with antiviral medication. He had also a previous history of orthopedic surgery, bilateral knee replacement, and he also developed an infarction, which it was necessary to put him a stent and to put him on dual antiplatelet therapy. His current problem is that he had aortic valve stenosis, and we had to do this replacement of his aortic valve. Also, the patient was on some standard cardiovascular medication. He got some antihypertensive medication, dual antiplatelet, as I mentioned, and some statins. But he also received something new. I didn't know also what it was, and it is emicizumab. It's a subcutaneous monoclonal antibody that mimics the function of factor VIII in your coagulation. It is necessary for these patients because if they receive factor VIII substitution twice a week, they might be developing antibodies against factor VIII. And nowadays they have this monoclonal antibody that mimics the function of factor VIII. As you see here on this drawing, you see the extrinsic and the intrinsic pathway, the extrinsic in red, the intrinsic in green, and you see that the emicizumab just mimics the function of activated factor VIII. Now, there are some special considerations with this medicine. When they monitor the APTT with these patients, as they give even low amounts to these patients, APTT is getting fairly low because of the medicine. It doesn't mean the patients are not going to bleed, but it affects the measurement of the APTT. You see here in this drawing, this was a patient without heparin with 0.5 units per milliliter heparin, and then with 1 unit unfractionated heparin in a plasma sample. And you see, even with heparin therapy, APTT is lower being measured in the lab. Also, if we look at the anti-10A levels, they are unaffected by the emicizumab. Also, coagulation tests based on APTT and chromogenic factor VIII assessments are affected. But the most interesting for us as perfusionists is in this publication that activated clotting time is possibly reduced, especially when you have to put a patient on a heart-lung machine. You want to be sure he's anticoagulated enough. That's why we found, I think 2 weeks ago, the very interesting publication of Tanaka, where we see that there's a difference between normal pooled blood, patients with factor VIII deficient plasma and factor VIII inhibitors in their plasma. They're all behaving differently. If you measure their ACT with or without emicizumab, and also with or without the delivery of heparin. Now, in the red square, it's the pathology of our patient, and we'll come back to that later on in this presentation. But you see that there's not much of a difference between the values of normal patients and the ones with the deficient plasma. You also see that the patient with factor VIII inhibitors in their plasma, they have much more insufficient coagulation. So these are the lab results of our factor VIII hemophilia patient. The INR was fairly normal. We also saw preoperative that the APTT was fairly lower, normal fibrinogen. Factor VIII chromogenic test showed around 20% of activity, but this was actually artificially incorrect because of the emicizumab. And there's a special test with bovine reagent, and we only saw that this patient only had less than 1% of his native factor VIII function. Also, we didn't find any inhibitors, and antithrombin 3 was around 71%. So you see, we have to find a balance in a patient we want to put on a heart-lung machine that has some kind of severe bleeding tendency, and we have to balance the patient towards a safe perfusion and also a good hemostasis after the bypass. But luckily, we weren't the first ones to being confronted with this. Last year, there was a very nice publication of a cabbage patient by the group of Isaacs, where we could steal some IDs already to get this patient safely from point A to point B and having his aortic valve replacement. Here you also see that the ACT values were fairly low to start, and that they, after the initiation of heparin and the bypass, everything went well, and they could perform in a safe way the perfusion of this patient. They also measured the heparin concentration levels, which we were also going to do. Now, this is the flow chart we came up with in a multidisciplinary meeting between surgeons, anesthesiologists, hematologists, and the bleeding specialists and the perfusionists. And we had a whole plan being made. How were we going to approach this problem? And the perioperative equipment, very interesting for perfusionists. We used the priming with plasmolite A and isogello. We did some heparin in our priming, just a standard protocol. It was a minimal access procedure, normothermic. We used Terumo EVIX-15 and EIOPA 20 cannula, nothing special, as we always do, no special circumstances. So everything went as we always do. Now, these are the values of ACT and heparin concentration during the surgery. What we did see was that before the induction of anesthesia, the ACT was 178. Then we gave 3,000. Sorry, there was a zero missing here. We gave 3,000 units of Elocta, activated factor A, and we immediately saw that ACT lowered, just to open the chest and to make sure the patient didn't have any bleeding tendency. After heparinization, we measured ACT, and all ACTs remained, except for this one, above 925. We also measured HepCon to make sure the amount of heparin on board was right. But we were sure, as this patient, as we saw previously with the Tanaka publication, as this patient didn't have any inhibitors and he reacted fairly normal to heparinization, that we were in a safe zone with the ACT above 999. Also, we could see that after the initiation of cardiopulmonary bypass, heparin levels were around 3, and they lowered down after cardioplegia. And here, when they were 1.5, we gave an additional dose of 1 cc, and then we rose back up towards 2. Were those doses necessary? Probably not, because also during surgery, we measured anti-10A levels in the lab, but we could only read them after the surgery was done, because the lab doesn't work that fast, the clinical lab, to give us these values. But here you see them. Before the surgery, our anti-10A level was 0. The first ACT and HepCon we did, we already had an anti-10A level of 8.9. And even when the ACT here dropped a little bit and the HepCon level showed us 1.5, we still had the anti-10A level of 6.4. So it was remarkably high at that moment still. Also, before, at the ending and after the protamine was given, we did a rotum. And what we saw was that all values were fairly normal, but the CT time of the heptem was still enlarged, around 270 seconds. We gave an additional 1500 units of activated factor A to this patient, and on the second rotum we did 10 minutes later, we saw that thromboelastography, the CT times just lowered. Also, the chromogenic test showed we had 50% of capability of factor 8. Because the emicizumab was still running around, we had to look at this test. Now, post-operative, we could see that the patient did well. We inserted an Inspiris valve size 23. Pumping time was 98 minutes, cross-clamping time 79 minutes. The total admission time in the hospital was 8 days, but this included 2 days pre-operative screening to make sure everything was right, especially hematologically. The admission time to the ICU was only 1 day. We had no bleeding complications and no major adverse events. Ooh. Sorry. Okay. So to conclude, it is feasible to put patients with hemophilia A and the monoclonal antibody with the emicizumab on the heart-lung machine, but still, it's a bit tricky. You don't know where you're flying through the fog, and you have a patient with a big bleeding tendency. You have to anticoagulate them. You can't monitor them properly. So you have to rely on your technology and especially on your knowledge to bring it to a good end. And I think teamwork, especially in this case, was the absolute most additional value of this case, because the interaction between all these specializations made a huge difference for this patient. So thank you for your attention.
Thank you very much, Kenny, for your presentation and sharing your approach in this special case. And for the next speaker, we go to Gerdy de Beukelare. We all know him as one of the driving forces of the EBCP as General Secretary. Next to that, he is Chief Perfusionist at the University Hospital of Antwerp. And we are happy that he wants to give us an insight in the quality framework he has implemented in his center to improve their daily perfusion practice. So Gerdy, we are all listening to you.
Thank you very much, Manu, for the kind introduction, and moreover for the invitation to have something to tell about our quality framework. I hope the first difficult part is okay, that you see my screen and you can hear me. The second one will be difficult as well. I will try to stay within the 15 minutes provided, because it's a topic where I could talk for hours. But as said, I will try to do my best to stay inside the 15 minutes. First of all, these are my conflicts of interest. I would like to tell you something more about our hospital. As said before, in Belgium, we have 29 cardiac centers, 7 Belgian universities. We are in the north of the country. You can see it over here in Antwerp. On the left top of the screen, you see the new building arised in the back of the hospital, where we are building 23 new operating theaters and ICU division with 60 beds. And our center is one of the centers performing around 500, 600 cases annually, but under COVID, it's difficult, but I think it's everywhere a little bit like that. Something to add, we have 11.5 million inhabitants in Belgium, so we have one cardiac center per 400,000 inhabitants, so that's quite a lot compared to other countries. This is my perfusion dream team. Myself, I started in the hospital in 2002 when I speak about perfusion. And since 2017, I became chief perfusionist in the hospital. And since that time, we had quite a change in the team, and we have a very mixed complementary team, and to be honest, a very stable team. So I call it a journey with the team when we talk about quality, because it's more about culture than only facts and figures. So the quality culture is not only safety, but it should be looked at in a broader sense than only the numbers. We only have 15 minutes, so I will try to give you some interesting books, some nice references to look up when you have the time. But for us, the culture of quality in the hospital and in our perfusion team is very important. The obligation to report or disclose, discuss and learn about quality, it's critical in quality culture. And to be honest, it's even the obligation of everyone that's involved in patient care to try to minimize mistakes by full and total disclosure. And that's one of the transitions we made with the team. In the beginning, we had to report in an anonymous way, but now we can discuss openly about incidents in the hope we can prevent it in the future. And that's really a team approach that's necessary for that. Quality in the hospital is not so strange, because every ward in the hospital has a quality board or a lean board. But for perfusion in our hospital, it's a particular one. Here you see our quality board with a lot of key performance indicators. But I will tell more about it. But once in the month, every division or in the OR, every cluster of pathology, they have a lean moment, meaning that we are looking at projects to improve quality. And that's the same for perfusion. Once a month, we have our meeting where we discuss quality projects when necessary. So when I talk about quality framework, we try to visualize it. It's not really in order of importance or in chronological order. It's random. So one of the important things we need for a quality framework is evidence-based perfusion. Is the first pillar of our quality in the framework. And this was already in place when I started and even before, so it's no big deal. But thanks to some smart colleagues from EBCP, EACS and EACTA IC, we have this milestone publication in 2019. And I hope, one, that you read the publication, but two, and perhaps even more important, that you did something with it. When I speak for myself and for my team, we had a meeting with our cardiac surgeons and cardiac anesthesiologists to see if we are working a little bit like the guidelines or not, because it's our recommendations, but important that you reflect about it in a multidisciplinary way. And I'll give a short overview of things we changed or added on our daily practice. One of the things we did was the implementation of the weaning checklist, because perhaps you recognize it. The moment you go from the heart-lung machine and you want to wean, it's always a difficult moment to have attention of everyone. And nevertheless, it's an important moment, and you really need a timeout to see if everyone is ready to have a smooth weaning of bypass. So what we are checking actually is the temperature. The picture is in Dutch, of course. If the temperature is okay, if the pacemaker has been tested, if ventilation is in full mode, if we have a correct pressure and systemic vascular resistance. And one that's not on the picture, but that we added recently is if the fluid balance has been completed in the record of the patient, because we saw that it has been forgotten sometimes, so we added to the checklist, and that's what a checklist is for. It's meant to be dynamic and that it can be adapted to the needs of every day. An extra measurement we added as well is the measurement of the pre-oxygenator, because we thought it was important to monitor the delta pressure over the oxygenator to see if there's something wrong and to be able to notice it as soon as possible. So second one is goal-directed perfusion. In the publication, I talked before, it's not mentioned as goal-directed perfusion, and I think it's a correct approach because goal-directed perfusion is only focused on oxygen delivery, but I think that it should be wider. And I think there's a lot of research needed to define link between more therapy and parameters we measure and outcome. This one is one that has been described by Professor De Zomer and Professor Annucci. It's an important one, but as you see, we often have hypothermic patients, and already for that population, it's not really relevant. So we always measure it, but it's hard to use in this particular setting. So it's important that we have more data and more research on that topic. And why is it important? When you think about the next step after goal-directed therapy, you talk about quality indicators. And as you see, we already have some quality indicators in our system. We have the oxygen delivery, where you can see that we have, for example, 98% of the procedure you're within the ranges you define in your system. What we also did was the flow estimation and the mean arterial pressure. But once again, we need correct measurements, we need definition of relevant populations, and we also need large databases to be able to have the necessary research for more valuable quality indicators. So EBCP certification, it's important. I don't think you expect me to say other than that it's important. But education in general is a key performance indicator for our hospital. We are an academic hospital, and over the institute, it has been defined that 2% of working time should be spent on education. And it's a hospital-wide key performance indicator. And this one is the one for perfusion. And as you can see, we almost reached 11.5%. It's way above 2% as it has been defined by the hospital. But we needed to have our recertification. And yeah, you know, since COVID is in among us, we follow a lot of webinars. So that's why we have quite a lot of points on the scientific part. For our team, we also measure the scientific and the clinical points. Here you can see the team amounts of points per quarter, per 3 months, from 2018 until 2021. And you see that we are having a trend to do some less clinical activity as before, but this is due to the COVID, and I think you will recognize it. And the same for the scientific points, we are going down a little bit. You see the trend line in the dotted line, but that's the same. We do our best to follow as much as possible webinars and stuff like that, but going to another country to follow the real congresses with the more amount of points is difficult or even impossible nowadays. So that's why we explain these trends. If you look at 2021, we have this slide as scientific and clinical points for the service. This is the first, second, third, and fourth quarter. And the lines are the minimum we need to have. And you can see that we are getting more than we need at minimum. We go even further. We even analyze per colleague. We have six colleagues. So this is the clinical activity, the scientific activity, excuse me, from last year. And this one is the clinical activity of each colleague. Participation in perfusion societies. Cornel already explained it. It's important to interact with your peers, to participate not only in scientific societies, but in perfusion society in general. When we speak about BelSECT, we had Matthias Allergaard, one of my colleagues, who was secretary and webmaster until last year. And he still is member of the education and training committee. And these are the people who are going out to have a practical examination and things like that. And for me, it's the same. I'm still member of the education and training committee, and I also examine colleagues, young colleagues in Belgium. And I'm general secretary and member of the accreditation and scientific committee of European board, but that already has been explained by Cornelia as well. One thing to know is that peer interaction is really important to develop yourself. And sometimes people say it's only for the young colleagues, but it's not only for the young colleagues, it's for everyone. And in this approach, we achieved to obtain the agreement in the hospital to have each of my colleagues, each perfusionist, they can have a site visit to another center once a year. So they can go there, they can look how people are doing things different or in the same way as we. They have discussion and it opens your eyes. And in the other way around, colleagues are always welcome to come to our hospital as well for the same reason. The next one is Perfusion Incident Reporting System, PIRS. This is one I liked a lot because it was one of the ways to start talking about incidents. We have some colleagues in Australia and New Zealand who did a lot of research and work on it, and it's really a beautiful project. But we started small. We adapted the registry to our needs. We used it for internal use, and we differentiated management and equipment related topics because we had the feeling that it's important to have those two separated. We register near miss and potential harmful incidents. It's a key performance indicator for the team. We try to achieve a certain level of incidents and we try to have a no blame culture because it's important to have psychological safety to be able to discuss open about incidents. So the transition we made was starting from an anonymous registration into an in-depth team discussion, where we always try to focus on the process rather than on people, because it's important to have process improvements to prevent more of the incidents happening. In the first part, we try to have a maximum level of incidents overall, but we started to have our indicator set on management part because it's very difficult to have impact on the equipment part. The equipment part we still register, but we only do it to approach our suppliers, to put some pressure, to compare with other suppliers, to have improvement in their products for our center. So when we look at 2021, you can see the 20% level we put, and we achieved to have incident level below. But I said low impact on quality of supply. So this is a difficult one to manage and to impact. So we started to look more at management, and we tried to achieve less than 10%. Last year, it was the first year we tried to achieve it, and we measured it, analyzed it separately, and yeah, we were correctly at 10%. And this is where the team approach is important. This is what you can impact and improve. So that's more efficacious as compared to the rest. This is overall registration, where you see that circuit error and electronic errors are more common. Very often, it's something difficult to impact on. We had some harmful incidents, and it was most of the time, always in our center, related to blood loss, because blood loss in our eyes is always or potential harmful or harmful, because it's tissue of the patient, so we have to be careful with that. I hope these are two images that are already familiar. We tried to use the DMAIC concept to improve quality, not only improve quality, but also to maintain the quality. And the process improvement we try to achieve is trying to fill the holes in the slices of cheese, in the hope we can prevent the incident in the future. Two good reads about this topic is the left one about Council of the Medical Colleges in New Zealand, a guide how to continuously practice improvement. And the second one, and that's a very interesting one, is a book about Safety 1 and Safety 2, written by Erik Holnagel. And when I show one figure, it explains a little bit. You see on the left what can go wrong. It's a small amount of all processes in your institution. Safety 1 is really looking and analyzing what's going wrong, but probably we might learn more if we look at everything, also to the cases that went right. And when we analyze that as well, I think we might improve more than only studying what's going wrong. But if you're interested, read the book. It's really recommended. The next one is automatic data recording. We switched from manual registration to automatic registration. We register every 15 seconds. It was the first step towards goal-directed perfusion, and I hope we will have more goal-directed therapy in the future. We try to look at quality indicators per case, but we are looking to have more defined, but it's difficult. There's not a lot of good research to have good definition of quality indicators. What we do as well is an export of the perfusion protocol into the centralized patient records. And we have our database of data where we try to analyze data and outcome. We try to look at procedure compliance, how you comply with the procedures we agree on, and also for tariffication. It's a part as well. And in the future, we would perhaps think about higher inter-hospital connectivity, where we should have larger databases to have more data, more power to do research. And this could be the first step to augmented or artificial intelligence. I think we should start with augmented before we can go to artificial. But it needs some language between centers, and I think we're still far away from that. We are also a training center. We train colleagues. We are one of the recognized training hospitals for the perfusion school of Leuven. It's the Dutch-speaking part of the country. And our trainers followed the trainer course in Leiden in the Netherlands, because we think it's important to have our trainers trained to be a better trainer for our students. And under development, we took our first steps 2 years ago, but COVID also came true. We tried to develop and participate in the Erasmus project to have people from other countries in our center. The next one is crisis management. It already has been mentioned by Cornel as well as a project of BelSECT, but we also try to think about the concept. You can see we defined 20 emergency situations, and it's divided in some parts. First, how to recognize a problem. What do you do first and what do you do second? We have defined some first and second actions. And we also try to write down something about differential diagnosis. And this is how we build it up in colors. First green part is how to recognize. Second one is first action. Then we have secondary action, and then we have differential diagnosis. We also try to set up an USA Simulation Center. Once again, it was also something for 2019. We were already exploring some possibilities to create a simulation lab, because it's really important. But here again, COVID came and it has been postponed, but we hope to pick it up soon again. It's important because we would like to train our perfusionists and also all disciplines around the table, surgeons, anesthesiologists, scrub nurses, and the perfusionists. From CRM standpoint, it's important. But we also would like to train for ECMO because we get a real demand from the ICU department to have things clear in their heads, to train troubleshooting, and that's an important one to do good care for ECMO patients. We also have external requests for training, not only perfusion and nurse training, but also the university, because it's part of a curriculum of the medical doctors in training to have simulation and to try to train scenarios. So to end, I have some take-home messages. In our center, the quality framework was a lever for a transparent safety culture, because it's not something you can get like that. You need to get the culture about thinking about quality smoothly, because there are a lot of pitfalls on the road. When we talk about goal-directed therapy and quality indicators, there's a long way ahead of us. We need a lot of research, and I think there's also a part for industry to develop systems to have a good parameter collection. Quality of the parameters is important. We should try to have large databases. Perhaps we should work between hospitals, even international, but it needs to have a uniform language to be able to couple these databases. So this is something to think about in the future. So I would like to thank you for your attention, and if you want more information or have additional questions, don't hesitate to contact me. Thank you.
Thank you very much, Gerdy, for your very interesting presentation. I hope you could inspire some colleagues who could maybe take over some of your ideas or go a bit in the same direction. So very well done. For the last topic of this evening, I am very proud that I can introduce one of our Belgian perfusion students. It's Dimitri Thijs. He worked several years as an anesthesia assistant before he made the step into perfusion some years ago. Currently, he's in the final year of his educational program and working at the Middelheim Hospital in Antwerp. And last year, they had to place a patient with sickle cell disease on ECMO. And even though Dimitri had to take written exams only last Friday, he is ready to give us a talk about the use of ECMO in patients with sickle cell disease.
Okay, thank you for the kind introduction. First, I'm going to share my screen. Do you see my screen and I'm loud and clear, Manu?
Yes, no problem.
Okay. Good evening, everyone. As Manu already said, my name is Dimitris. I'm a clinical perfusionist in training at the ZNA in Milan. Today, I'm going to talk about the use of ECMO in patients with sickle cell disease. Due to the limit of time, I'm going to go over the core topics. There was a 16-year-old adolescent female who was admitted to the hospital for urgent placement of a VA ECMO. Unfortunately, that wasn't possible, so she went on a VV ECMO. The core topics. First, I want to talk about what is sickle cell disease. Sickle cell disease is an inherited genetic red blood cell disorder that affects the hemoglobin and can cause sub and lethal destruction of red blood cells, and also has a coagulopathy. You have two kinds of sickle cell disease. You have sickle cell disease and sickle cell trait, but there's a difference between them. When you talk about sickle cell disease, the sickle cell gene is inherited from both parents. That's the most severe form. In the literature, that's also referred as the homozygote type, and that's one to remember. That's also pointed as the hemoglobin SS, because two genes are involved. On the other hand, you have the sickle cell trait. There's only one sickle cell gene that is inherited from one parent, and also called hemoglobin S, or the heterozygote form. Sickle cell trait is more common and less severe than the sickle cell disease. Other subtypes exist, but are not so relevant for this presentation. If we have to talk about sickle cell disease as a whole disease, I think we can talk for hours. There's something very interesting in the prevalence of sickle cell disease. Sickle cell disease is predominantly within people of African descent, 80%. The other 20% is from Mediterranean and South Asian descent. I looked it up, and there is some explanation why the African people are so predominantly. Because there is a link to malaria and the resistance to it. So if you look at the sub-Saharan Africans, you see when there is an incidence of malaria, there's also a high incidence of sickle cell trait. So it has, if you have malaria and you make some resistance to it, you also have a mutation of the hemoglobin, and that's the sickle cell trait. Another case is that 69% of this has the sickle cell trait, and only 4 has a sickle cell disease. Today, we only talk about 40% over that 4%, because they are of interest for us, because if there are problems on the ECMO, it's the 4% that will matter. To understand what's the sickle cell causes, if you look at the pathophysiology, sickle cell turns a normal hemoglobin in hemoglobin SS due genetic mutation. When triggered, hemoglobin SS will deform the red blood cell into a sticky sickle cell shaped red blood cell. The problem is when sickling red blood cell can block and damage blood vessels, causing pain, tissue ischemia, and subsequently organ damage and an acute chest crisis. In particular, that last one can be life-threatening. We talked about sublethal destruction. In sickle cell, there will be a deformation that can lead to impaired O2 carrying capacity. Not only that, but if you look at the form of a red blood cell, it's a concave shaped disc, so it will be stiffer and it will be harder to deform when it comes in the microcirculatory. Another problem is hemolysis in these patients. You have an acute and a chronic form that can lead to high concentrations of free plasma hemoglobin. The problem with free plasma hemoglobin is that it can give a depletion of its scavengers, haptoglobin and hemopectin. When those two are exhausted, it will lead to a decreased level of nitrous oxide because of the binding of free plasma hemoglobin to the NO. We'll talk about that later. Also, sickle cell patients exhibit high levels of thrombin, tissue factor generation, and a normal activity of the fibrinolytic system that can lead to hypercoagulable states. Here you see on the right a normal red blood cell, and on the left you see a sickle cell shaped form, and on the other side you see the sickle cell blocking the blood flow. There are some triggers that can trigger a sickle cell disease crisis. First of all, a very important one is the ischemic conditions, where we think about ischemic conditions like hypoxia, hypo and hyperthermia, acidosis, stress, dehydration, and excessive exercise. If we talk about the treatment, you have two options. In the normal circumstances, patients get a pharmacological treatment. The golden standard is the use of hydroxyurea. The active agent is hydroxycarbamide that increases the fetal hemoglobin. So there will be less hemoglobin SS, and then therefore it will decrease the attacks. In sickle cell disease is the first choice of treatment to lower the incidence of the sickle cell disease crisis. And most important factor here is the therapy compliance. There could be multiple factors of adherence. In the case of the young female I have talked about, there was a religious problem where the mother said, you can't take your medication because there's some religious problems. So the young girl was in 1 year time 15 times hospitalized for acute crises. Another one is the transfusion. Why transfusion? In particularly the exchange transfusion to lower the HBSS on 40%. Also, of course, the treatment of anemia. Here is very important that there is attention must be given to the level of ACT and more to the viscosity of the blood. Well, what is the use of ECMO in these patients? First of all, 85% of ECMO use is in the type of the VV ECMO. Of the vaso-occlusive crisis that will progress in acute chest syndrome. In 15%, we see the use of the VA ECMO due to coronary ischemia leading to myocardial infarction and cardiogenic shock. There are some considerations when you use ECMO in patients with sickle cell anemia. The first one is the pH strategy. It's very important to try to avoid metabolic acidosis and to maintain a pH of 7.38, to 7.45, because the metabolic acidosis is very important to triggering to sickling. Something I found in the literature is that the best way you can treat acidosis in this case is with sodium bicarbonate, 8.4%, but I think that will depend on the protocols in the hospital. Another thing that is very important is to use stable solutions of IV fluids. Try to avoid natrium chloride 0.9% and plasma expanders. the nitrochloride because it can give hypochloremic acidosis, and plasma expanders are have a very low pH. Another one is the activated clotting time. You can ask from why is that? In a few case reports I've read, their sickle cell is known for falsely low ACTs after full heparinization. And then we talk about 500 to 600 units per kilogram body weight. This can be caused by abnormal platelet aggregation. The advice is here, if you see low ACTs, to investigate further with viscoelastic correlation tests. And also, these reports, they say the method of ACT control can be of influence, and then in particularly the mechanism of action. The other one, the ABSS, tried to maintain low levels between 20 to 45% of the total hemoglobin. Lowering can be done by the infusion packet cells. Something to consider is don't go above 40% ACT. It's not recommended due to increase of viscosity. When the hematocrits rises, viscosity will rise, and that will increase the shear stress and also will decrease the microcirculation. SA2, SVO2, I think that will sound easy and common, but you have to avoid hypoxemia. Again, it's one of the most important triggers. Also, you have to avoid hypoxemia in the as well as in the arterial as in the venous compartment. If you have a good saturation in your arterial compartment, that's good. But if you have a low SVO2, sickling will happen in the venous compartment. So try to maintain an SVO2 above 95% and SVO2 above 60%. It is advisable to continuous measurement of SVO2 and SVO2 continuously on the ECMO lines. Another thing of consideration is the ECMO setup. It is recommended to use coated lines in the ECMO to minimize the contact activation. Also, make the choice of a high capacity oxygenator with a long blood path to avoid hemolysis. You will have a higher delta pressure, but you will have a lower shear stress. I think it's since the sickle cell the patients have higher hypercoagulable state. Excuse me for my words. I think it's very important that the stagnation of blood within the oxygenator has to be minimized. So I think you have to be careful with the oxygenators with a lot of corners. Fluid balance, always maintain a positive fluid balance. Caution with the use of diuretics, and also mentioned earlier, be careful with large amount of NaCl, 0.9%, to avoid hypochloremia. And strict monitor diuretics is advised. Nitrous oxides, when free plasma hemoglobin concentrations rise, its scavengers haptoglobin and hemopexin shall decline, and free hemoglobin will bind to NO. So it could be of use to supplement the supplementation of nitrous oxide through the oxygenator. It can reduce pulmonary hypertension and a reduction of platelet activation in the oxygenator. Also, the use of human haptoglobin in experimental settings has been given, but there is no evidence that there is a better outcome. So, to the conclusion, sickle cell disease is not common in Europe. I think this is a story that contributes to the larger picture of severe hemolysis that can be seen in the use of ECMO. Some considerations are specific to sickle cell disease, and especially think about the ACT and the environmental conditions that can trigger sickle cell disease. Well, that was my presentation. Questions or remarks?
Thank you very much, Dimitri, for your interesting talk. Given the time, we will not be able to answer questions live. So I would like to thank our speakers, Corneel, Gerdy, Kenny, and you, Dimitri, for your talks. I want to thank the EBCP for the support, and all of you for your attention and your enthusiastic reactions in the chat. So have a nice evening, and see you the next time.